So thank you very much to all the speakers for keeping on time. We're now going to move to the panel discussion, and to kick this off, we will have some introductions by our advocates, Gwen Darien and Dr. Nicole Stern. Unfortunately, Mary Scroggins is unable to be here today. Her husband is very sick, and she needs to be by his side. I'm Quaker, and what you say in Quaker speak is to hold somebody in the light. So I paused for a second just to think of her and her struggles right now. So I think the first person is Gwen Darien, and you'll start with some comments.
Great. Thank you, Vicki, and thank you to all the rest of the speakers and to Dr. Wynn and the organizers for inviting me. I'm Gwen Darien. I lead patient advocacy and engagement at the National Patient Advocate Foundation and the Patient Advocate Foundation. And I just want to say I have a couple lenses through which I'm going to give my brief comments and bring up just a few issues that I think we need to talk about as we look through as we go through our discussion and as we go through the day. So first of all, my one lens, and the lens that got me into advocacy, is that of a cancer survivor. I was a young adult cancer survivor and changed my career, like many people, and now I'm a 3-time cancer survivor. So it has been an extraordinary time being an advocate over the last over 20 years, and some of the people in this room I've known for at least 20 years. I have an identity. The other identity in the lens is as a leading this sort of intersection, as you'll see, the Patient Advocate Foundation and the National Patient Advocate Foundation, where we work at the intersection of direct patient services and system change. And our patient population is primarily insured at this point at post-Obamacare, but very much underinsured and very vulnerable for many different reasons, including an average household income of $35,000. And then I was thinking of the other lens, which has become more and more apparent these days when Beth was talking about surnames. So my surname is Darien. That's been my surname since I was 3. But I was born Gwen Gashgai. And Darashuri is the other name, that our family name. But if right now I am the daughter of a father from a banned country, which is a very strange change in the way that our identity goes. So one of the things I wanted to talk about a few things. Identity is mutable, and social stigma and bias change over time. And those are things that we have to remember when we look at this context of how we use big data for social determinants of health. One of my jobs as an advocate, I think, is to both say things that are thought-provoking, but also bring out things that are unsaid, that are implicit, but that aren't explicit. And I think one of the things that we haven't quite said here is that equal does not mean equitable. And I think that's one of the underlying frameworks of this conversation, is that we're not trying to get people equal treatment and equal access. We're trying to move to the point where it is equitable. And equitable is also a moving target. It is not something that stays the same. We're all looking at closing this gap. We're all looking at closing the gap between discovery and development of new treatment and delivery and healthcare delivery reform, where everybody benefits from the biomedical progress as well as the resources that this country has. The other issue that is incredibly important is trust. It's come up across all of these different speakers. But most of the time when we talk about trust in terms of having patients trust the system. We don't talk about how the system has to trust the patients. And if we don't have the system trust the patients are never going to trust the system. And we see that all the time, depending on what your social economic status is, what your ethnicity is, where you live, what your age is, what your education. There's so many different aspects that affect that trust, and so many different ways that patients are profiled, and that families are profiled when we go in and we get health care. The other thing I think is incredibly important, and my colleague Joel Gurin is here from the Center on Open Data Exchange, and we just did Joel and Mona Siddiqui, who is the Chief Data Officer at CMS, just organized a roundtable on privacy and using big data for public benefit. And one of the things that we haven't talked about, we've skirted around, is the fact that the social part of the data, particularly as we're collecting real-world data, is not protected or covered by HIPAA. So if we don't build that trust and we don't build this kind of, if we don't build protections, a lot of the data that we need in order to address the social determinants is data that is not protected. And that is particularly, a particular concern to, I think, pretty much most people, but particularly vulnerable populations. Then I think that, finally, I have 7 seconds, finally, eliminating, no, we have 5.
We have 10.
We have 5.
Each.
5. So eliminating disparities by using data is both a matter of political and social will, and it's also a matter of creating protection for the data. And we have got to, I remember a number of years ago, Doug Lowy talked about who is now acting director of the NCI, talked about eliminating cervical cancer was a matter of political and social will. Well, eliminating disparities and eliminating bias in these disparities is also a matter of social and political will. And we have to get to the point where we believe that this is something that is truly I think everybody in this room believes in this, but we have to go beyond this room and speak to people within this room. I don't remember whether it was Paul or Dave who talked about bias in and bias out, but we have to assume that the bias is in, but we have to commit to getting the bias out. So thank you.